Hello, welcome everybody for our grand round. It's a real honor and privilege to introduce Dr. Bambakidis. He's from Case Western University, originally native of Ohio, went to Wright State University, and then went to Case Western, did his medical school, his neurosurgery training there, went to the degree BNI, where he did his fellowship there, he's dual trained, he's got, 80 publications, big books, very active in academic neurosurgery, he's a real leader in vascular and cell base, and really heir apparent at Case Western. Did a lot for organized neurosurgery. We're very fortunate. He works with the CNS Executive Committee, he's involved with the SNS, and all the other societies, and he really does a great job. So without much further ado, I didn't ask, and I always tease him about this, our better half are our wives. He's married to Kim with 2 great kids, so without much further ado.
Thanks, Neil. Boy, the last point is the best one that you made. But thanks for having me come visit. Really, we had a great afternoon, went over some great cases with your residents, great group of folks here in Shreveport. Just in the next few minutes, what I wanted, when you invited me, I started thinking, what am I going to talk about, this bastion of skull-base surgery here? The last thing I wanted to do is come down and show cases or anything like that. It's like speaking after Robert Spetzler about AVMs or something. But I did want to talk a little bit about something that has interested me and is becoming more and more apparent in everything that we do in medicine. And that is the socioeconomic aspect of medical care in the United States. And referred back to something that's obviously very near and dear to my heart, and that's the management of subarachnoid hemorrhage patients and aneurysm patients. I think it's still the most gratifying sort of treatment options that we have to offer our patients, curative from a lethal disease in many cases. And so I've been doing some work over the last few years with some of our residents who have really been critically involved in putting some of this data together regarding cost and regional variability, which I'll give you some insight into in the United States. It can be quite eye-opening when you delve into it. And then just leave you with some ideas of the potential impacts nationally and also locally, because all politics are local. And I'm sure Anil can tell you stories about talking to your administration about the cost of treatment and what you may want to change or alter. High reliability medicine is probably a buzz term that everyone has heard. Every major hospital system is doing some sort of work in this space. And so neurosurgeons, we're a very critical piece of healthcare delivery, a small but critically piece of healthcare delivery, but a very resource-intensive piece of healthcare delivery. If you think about the technology that we utilize to take care of patients with some of these complex issues. So I'll frame some of this in the discussion, and please feel free to interrupt me at any time. It's a small room with any questions about any of these things that we'll go through. I think, again, aneurysms, we know, the question really is, should cost matter in the treatment decisions? And the answer really is, it should at least give you some information, okay, about what you're doing and impact your thinking at least a little bit. I'm not advocating that it should be the driving motivation behind anything that we do or offer to patients, but again, it's an era of healthcare reform. Everyone, again, is exposed to target cost containment strategies, again, from a national level down to your local hospital level. Things like Medicare costs, this advisory board that was strengthened in the Obama budget that's basically charged to rein in Medicare spending may become a reality. I'll try not to talk too much about politics. Since I am from Cleveland, we might see a giant sinkhole in July. We're not sure what's going to happen, but as responsible members of the healthcare delivery system, we want to be aware for the costs for the treatments that we advocate for our patients. And some people would argue that it's silly science looking at cost and how much does a coil cost versus a clip, and shouldn't we really be doing research about should you clip a 34-year-old patient with an 8mm PCOM aneurysm or coil her, what's better for her long term, or the 74-year-old, the same incidence? How do patients do at 1 year treatment? Should patients all be transferred to tertiary centers? Those are all very important research questions as well, but I would argue that looking at some of this information is equally important. So again, in this era of hyperpartisanship and mudslinging, you know, you always want to go back to your founding fathers, and you can't visit a Neil Nanda without quoting somebody, right? So I did quote here Thomas Jefferson, couple sayings to live your life by. Never spend your money before you have it. The government doesn't do the top one really well. And never buy what you don't want because it's just because it's cheap. My wife doesn't listen to that one either. But anyways, a couple of important points to keep in mind. So here, I'll just show you just a few cases here just to illustrate some of the points that we're trying to make. These are obviously extreme cases, but here's one of them, a 34-year-old woman with headaches. She has 2 aneurysms here, one on the right side, both paraphthalmic, one on the left side, quite large, wide neck, young woman, recommended treatment first of the uglier looking one on the left. And in her case, we decided to use a flow diverting pipeline stent. She was a Plavix non-responder though when we tested her, so we had to put her on Effiant, which is not a cheap medication. Treated her, went fine. Her headache worsened for 6 months afterwards, however. And then we elected to bring her back for the right side because of issues with bruising. She didn't like the medication, so on and the morphology of the aneurysm, to do a trap bypass on the right. Now the bottom line with all this was she is out of network for procedures performed at Case Medical Center at UH, but nowhere else in our system because of who knows what, through medical mutual. Anyway, so she ended up, we didn't know a lot of this going in. She ended up paying out of pocket $21,000 for her pipeline and another $5,000 for the trap bypass. Everything went fine, but you know, these things do have real-world implications for our patients, many of whom seek us out to provide expert quality care. And a lot of times it's just buried in our minds, particularly at our levels. We just often don't think about them, and we should. And I think it's particularly germane when you think about unruptured aneurysm treatment. It's really still a medical conundrum, right? The management is still controversial. The natural history is still unclear. There's conflicting data in the literature. We know size does matter, but we all know our unit's full of 3-millimeter ruptured ACOM aneurysms, right? So who should you treat and when and how? And so it's a puzzle, it's an enigma, it's something we're still working out. If you look at management trends, so this was a review of 34,899 hospital discharges, ruptured or unruptured cerebral aneurysms, 1998 to 2007. Nationwide inpatient sample is a Medicare database, okay, using hospital DRGs, so there's some limitations there. But in conclusion, you can see, looking at ruptured aneurysm pre-2002 to post-2002, the ratio of coiled patients, you know, increases 5 times what it was, and not dissimilar in unruptured cases. And you can see that here in the graph on the right. The coiled cases after about 2002 skyrocket, and clipping starts trending downwards significantly. And so this has led to dramatic increases in the treatment of unruptured aneurysms throughout the United States. And you can see that here, total treatment here going up over the, again, 2000 to 2006. Most of that is endovascular treatment. A lot of it is in community hospitals. You need a biplane machine. You need a basic ICU set up for a day or 2 hospital stay. It doesn't take a lot in terms of infrastructure. So you can see that that's had a major change in terms of, and you can see the craniotomy numbers continue to decline. Now, it is interesting when you look at newer data over the last several years, the trends have sort of leveled out. And this is ruptured aneurysms now, Medicare beneficiaries. Coiling sort of leveled off. And clipping numbers have actually gone up a little bit. And in unruptured aneurysms, we see something similar, although now you see initial drop in coiling, rise in clipping, last few years. That is sort of reversed. This is probably flow diverting stent utilization for unruptured aneurysms, right? Not in use for most ruptured cases. But as the new technology tends to roll out, you can see upticks, so some of the newer things that are coming on the market. Nevertheless, you do see some of this leveling off of open vascular cases, and I think it's because people have come to realize, I certainly have, that there are limits to the new technology, that you can still have equivalent or better results with the, quote, old-fashioned techniques, which continue to get better and safer with things like ICG, better microscopes, and flow measurements, and so on and so forth. What's interesting is that there's still been no change in the rates of subarachnoid hemorrhage in the United States. Still exact same number of cases of subarachnoid hemorrhage in the United States. And that's borne out, you can see, I thought I had a graph here, but so that shows you that we really haven't impacted the disease overall. And what shows you that we really don't understand the natural history. We're over-treating people and still, for whatever reason, not necessarily selecting out the folks that are going to end up rupturing. Okay, so there's something intrinsic in aneurysm biology we still don't understand. The other point that I think is worth noting is this tremendous regional variation in how patients are treated. So depending on where you have your aneurysm diagnosed or where your aneurysm chooses to rupture, the type of treatment you're going to have is primarily determined on that geographic location in the US. So you see here unruptured cases on the left, ruptured cases on the right. For unruptured aneurysms, if you live in these areas, you can look at the spread here for unruptured cases. It's all over the place. Same for ruptured cases. If you're in Tacoma, Evansville, Des Moines, it doesn't matter what your aneurysm looks like, what the shape of it is, how big it is, how old you are, you're going to have it coiled. Whereas if you're in some of these, Madison, Anchorage, San Diego, you're still going to have clipping recommended. And for ruptured, we see the same kind of thing. Nashville, 96%, Fort Lauderdale, coiling in almost every case. Chicago, Dallas, Phoenix. Not unusual, larger, better, well-known academic neurosurgical powerhouses. I don't know where Shreveport is on this dot. I didn't check, but yeah. But I think we're doing probably 30 to 40% clipping in ruptured cases, 60 to 70% endovascular, and 50-50 for unruptured. I think most places that have a lot of expertise are probably doing very similar numbers and don't see these huge extremes. I think that's pretty unusual. But nevertheless, it's a huge spread. And this is just the United States. I mean, you can think about it in Europe. If you're in Finland, you know you're going to have it clipped, right? Whereas if you're in France, forget about it. You're getting attacked with platinum. It doesn't matter. So I think that you see this same sort of picture play out, and so the science isn't really being followed, and the expertise is not evenly distributed. So one of the other points I wanted to talk about a little bit is this notion of quality. Okay, the government knows what quality is, right? Well, they're going to tell you, at least try to. We're not very good at measuring it ourselves as a profession, but we can get some data about how patients do. And if you look at Medicare data, ruptured patients do tend to stay in the hospital a bit longer. They tend to go to rehab a bit more. The readmission rates are actually a bit less for clipping, and that's probably because, again, you're looking at Medicare data, right? So you're having older patients. My guess is if they're being selected out for clipping, they're probably the healthier folks that you think can undergo surgery a bit more safely, and so they may end up not going to rehab as often as patients who are chosen for coiling, or if you're selecting out poorer grade patients for endovascular treatment, they may end up being readmitted more frequently. For unruptured cases, again, you can see what you probably would expect, the length of stay for endovascular treatment, about 1 day. For clip patients, it averages 6.5. And again, these are Medicare patients, right? We all talk about our 40-year-old unruptured aneurysms usually go home in a day or two, even with arterial and craniotomy. But for older folks, it's a bit longer, and they tend to go to rehab a bit more. But again, the 30-day readmission rate is a little less in clipped patients. Again, probably because you're selecting out healthier folks who maybe you send them home a little too soon, they look good, they come back with a UTI or something like that. Now, of course, I mentioned the government and quality. There's a million acronyms out there that as residents, you have enough to worry about as a neurosurgery resident to learn about, to study for boards. But you still need to be sort of familiar with some of the stuff that's happening on a national level. And you talked about, the stuff that we've been doing on the Washington Committee, trying to deal with some of these issues that keep cropping up. PQRS is a part of a Medicare fee schedule repayment quality metric that essentially will adjust down Medicare payments depending on the measures that the government, CMS specifically, is putting into place. And they're not neurosurgery specific quality measures. They're the things you've all seen, urinary tract infections and sepsis and things like that. And it's tied to this value-based payment modifier. It essentially is a way to reduce reimbursement to physicians in the name of quality. But there are potential for non-participation are significant. This is one of the drivers behind consolidation of physicians and physician groups and the trend for neurosurgeons and other physician specialists to become hospital employed. We were talking about it with your residents earlier. The costs of participating in these programs, putting in your EMR, they get prohibitive for some groups. And so that's why you see increase. One of the reasons you see an increase in hospital employment. And again, they're not neurosurgery specific. Participation is extremely complex. It's not easy. That's why often you'll just need a team of administrators to run around and help make sure you're dotting all your P's and your Q's, your I's, and so on and so forth. And you can see here the potential for cuts with all of these things coming are not insignificant. Electronic health record, if you're not participating in all these things, they could add up to a substantial reduction in Medicare reimbursement. Now, there is a trend in organized neurosurgery to come up with neurosurgery specific outcome measures. The N, it's not N2 now. What is, they cut one N out, do you know? They get QOD anyway. So essentially it's a central registry designed primarily initially for spine patients, lumbar and cervical spine modules, where reporters now can choose 9 specific neurosurgery specific outcome measures, and recently has been approved as qualifying for one of these PQRS reporting requirements. And there's a vascular module which is now enrolling, which we've just started enrolling. I don't know if you're participating in QOD here, but it is labor intensive putting the data in. You do have access to it later that you can use for your own process improvement and research. It does take an FTE or 2 FTEs, but one thing that does get your hospital administrations piques their interest is that, hey, you can satisfy some of these requirements, so maybe the FTE is worth it to provide to the department. And so those are the sorts of discussions that we're having going forward. And I think the intention is to try and get it rolled out, not just obviously for spine and vascular, but for tumors and the rest of neurosurgery in general. So just a couple more cases just to show you again this sort of how cost can come up in the care of our patients. It's another lady, she's 54, visual changes, 2 first-degree relatives with subarachnoid hemorrhage, large multilobulated aneurysm. Again, decided to go ahead and use newest flow-diverting stent. This is one of my earlier cases with Proctor, and here we were concerned. There's endoleak here and apposition, not good coverage of the carotid. Anyways, we put in 3 of these, and then the ICA occluded after we replaced the 3rd one. And we were able to open it after mechanical dilatation. Went through what I like to say endovascular calisthenics. Anyone who's an endovascular person knows what I mean. Navigated an ACOM, through the ACOM with catheter, and you can see from the other side to balloon that what had happened, one of the small stent tines that sort of become deformed. So we dilated it open, gave her intra-arterial antiplatelet agents. She did fine, the carotid's open. We had a stack of trash up to here by the time we're done with that. The guys are nodding. I mean, it's just, sometimes you get into these into these situations, and that gets you a call to the principal's office sometimes, right? I mean, that gets somebody's attention, $120,000 of implants, and what are they doing downstairs? So, just something occasionally that does come up, and people have looked at this. Brian Ho looked at this at his own hospital in 2009, coiling versus clipping ruptured, unruptured aneurysms. Found that, as you may expect, coiling, shorter length of stay, higher total costs that he attributed to the implant costs of endovascular treatment. That was a single institution study against lumping together ruptured and unruptured cases. If you look at the NIS, which Brian did and published later in Stroke, he found that clipping, again, longer hospitalization for both ruptured and unruptured patients. Again, this is the Medicare database. Clipping associated with $15,000 more in total costs for ruptured aneurysms and $11,000 in total charges for unruptured aneurysms. And in a follow-up study in 2012, found the charges were not, and this is another study, that really the charges aren't significantly different for younger patients. It's the older patients that you see those clip charges become significant. And that's probably related to the length of stay itself. Staying in the hospital is obviously very expensive. And the cost for ruptured aneurysms is really more dependent on how sick the patients are when they come into the hospital than anything else. Really, the impact you're going to have is on the unruptured cases. On the ruptured side, again, they come in with the certain high-grade patients, medical complications and comorbidities. That impacts things much more than anything you do to them interventionally or in the operating room. What's interesting, though, of course, if you look at what Medicare pays you for taking care of these patients, really in actual cost, it's about $80-some thousand to take care of the typical subarachnoid hemorrhage, and depending on the DRG for Medicare payment is between $36 and $50-some thousand. So you lose a lot of money on Medicare folks managing them, and they come, where do they come? They come to the academic medical centers, right, which bear the cost of all this. And one of the big things, I'm sure you have the same issue here, how can we break even on Medicare patients for taking care of them? It's a big issue. I'll just end with one last case, 81-year-old progressive visual loss, enlarging ICA aneurysm. I decided I hadn't had enough of these flow diverters, so I just went ahead to try and put another one. You can see it's very challenging when you get into one of these situations where you're looping the catheter to get access. But in this particular case, the stent, I thought it deployed, and it didn't across the ICA, deployed in the aneurysm. So we ended up having to take her back for coiling, and that primary coiling, that didn't work so well. Ended up just occluding the carotid artery totally. But again, with this, again, over $100,000 of implant costs, where you could argue, a little ligation and a $10 suture would work just as well if you decide to treat her. But it's only after you get into these sorts of things you start thinking about it. Because each one of the stents is about, I'll show you, about $12,000, $15,000. The coils are about $3,000 to $4,000. And an aneurysm clip is about $300 to $400, depending on what kind of deal you've made with the manufacturers. So, this, again, you get called to the principal's office sometimes with some of these cases. So you got to go back and look and see, hey, what are we doing, and what impact can we have, and is there anything we can do that can affect the socioeconomic impact on our patients and on the profession. And so we looked at our aneurysms over a 3-year period. Yifei Duan, one of our residents, and Jeff Nelson, our endovascular fellow, put some of this together, both ruptured and unruptured aneurysms. And I think an exercise like this, frankly, is useful just in practice on a regular basis, looking at the specific portion of your subspecialty, because an honest assessment of your own results and your own data is very, very important. But not just early in your practice and not just later, but throughout. And what we found for all comers now, if you look at ruptured and unruptured aneurysms over this period of time, 270 coiled, 312 clip. Length of stay, very similar, significantly longer in the clip group. If you take the outliers out, though, the patient we all have that stays, has every complication, is there for 45 days. If you take those patients out, actually it's very similar. The hospital costs are very similar as well. Strong trend, but not statistically different. And the readmission rate is very similar. What does this show? Well, this again shows what we had talked about earlier, that for ruptured cases, it primarily, the impact is primarily on how sick they are when they hit the door. That's really what was going to make the main driver of that calculation. But now what about unruptured aneurysms? So we decided just to look at it quickly. We took a matched cohort. Okay, so you take 27 patients at each side, matched for sex, age, supratentorial aneurysm, get the sizes fairly close, comorbidity, so on and so forth. You can see here. And just compare them. Again, here's our and this may be different for every hospital, right? It depends on how your hospitals negotiate with your device manufacturers. At the time we did this was about what we were paying, $1,200 per coil. Stents themselves, I'm not talking about a flow diverting stent. Neuroform Enterprise, about $5,200 and $12,000 for a pipeline. And you can see here that in this match cohort, the length of stay is, as you might expect, again, significantly longer in clipped patients. The mean total direct variable cost, so this is the implant cost, though, much higher in the coil patients, about almost 3 to 1, not quite. The mean total cost, hospital stay indirect, so this is keeping the lights on, the nurses and the administration, all that, so on and so forth, about the same. No significant difference. And you expect that from this length of stay data. So what does that tell you? That tells you if you can decrease that length of stay side on clipped patients, you can really start affecting this number significantly. So we're trying to get our uncomplicated, unruptured aneurysm patients, not putting them in the ICU, watching them in PACU, getting a CAT scan if we think we need it, regular hospital floor, try and get them up and moving out of the hospital within 2 or 3 days. And for coil patients, it's always been a 1-day hospital stay, but also trying to avoid the ICU when we can. And then the last line is mean additional cost. So this represents the stuff you do in the year after you take care of these patients. And these are the 2 MRIs you get on every coiled patient, the occasional angiogram, and basically nothing you're doing on the clip patients, maybe a CAT scan or something, because you don't have to monitor them as closely. And so we found a lot of this, just going through this exercise, I would encourage you to think about it. Every resident should be involved in some kind of quality improvement, high reliability medicine project. We try and get our folks involved. If you go down to the quality office and say, hey, I'm interested, I am sure they have projects that they would love to have any of you guys and gals involved with. And you can get a paper out of it, you can get a presentation out of it at national meetings, and you can help your own department, you help yourself in terms of learning more about the profession. But in conclusion, so again, nothing new here. Endovascular treatment is a dominant method of treating aneurysms in the United States now. It's about 70%, but clipping rates have stabilized for subarachnoid hemorrhage. They continue to fall for unruptured aneurysm treatment. And again, that's probably related to limitations of the technology, at least for ruptured cases, and then new technology for unruptured cases like flow diverting stents, which, however, as you can see, it can be quite expensive to utilize. There's tremendous regional variability across the United States and throughout the world. And I do think that we ought not understate that some of these registries and outcome measures, if they're driven by leaders in the profession, will provide improved methods to inform patients and improve patient selection. If it's left to folks in CMS and non-professional, folks not in the profession, I think they will be much less helpful to us and maybe to our detriment going forward. I do think manufacturers, now they have responded to some of the cost reduction in endovascular products. They're coming out with longer coils, so you can use lower cost incurred per case coils that are thicker and have more of a filling capacity to them. That's driven by competition amongst manufacturers being driven by some of the economic data. So I do expect that some of those numbers will drop with time. And again, I didn't mention the length of stay issues that we all, not just, and you have to be a little careful, right? When you try and drive length of stay shorter, you have to be careful that you don't drive the readmission rate higher on the back end, your 30-day readmission rate, right? So you have to balance that. We use things like, close follow-up, nurse phone calls, so on and so forth, the residence clinics if needed in the immediate post-op period to try and head that off. But there is something to be said for trying to shorten that. And a lot of that is expectation too. I mean, if you talk to your patients ahead of time, set up the expectation that you're probably going to be going home in 2 or 3 days. That's different than if you don't have the discussion and Dr. Bambakidis kicked me out of the hospital in 3 days when I thought I was going to stay for a week. So, a lot of it is expectation that can be managed as well on our side. And then, of course, new technology and industry push, it's something we just have to balance in this new world of healthcare reform. And I think, all of us, as we get more involved with the hospital administrative side, we see that it's just an opportunity where you can work to reduce overall costs and improve financial performance, and then you can get to, and we like to talk about this at UH, and the administration beats it over, no margin, no mission. You can talk about, education and research, but, you have to pay attention to some of these important drivers going forward, particularly, again, in a resource-intensive field like neurosurgery. So that's all I had. I want to thank you again for having me come. It's been a terrific day.
That was really a brilliant talk. I think I'm glad the residents were here and our fellows are here too, because this is going to be a huge topic. I mean, I think what people talk about is the geography of testing. And I think I'm glad Anthony is here, because this is what you're seeing in spine surgery. That you will have a laminectomy in Florida. If you're in Florida and New York, you're 4 times likely to have a laminectomy in New York than you are in Florida. There's huge geographic disparities, and that doesn't equal better quality. So that's really brilliant work that you've done, and I think this is a real good sort of Rosetta Stone for the residents to think about. One of our residents is doing a year of public policy.
I heard he's not here though tonight.
I know, but I might send him a copy of your talk, because he's really the guru on this, and he's very interested in economics. But I think this is great stuff. Are you trying to do this for spine? Like, I'm curious, Christina, for pediatrics, what is the national trend of ET lead over shunting? Like, that's a question. Has that been looked at or not? I'm curious about that. Is that, who would have thought 10 years ago, before ISAC came out, that clipping would be 30%? I mean, nobody would have predicted that. So it's a disruptive innovation. I think it's a great disruptive innovation. It's better for our patients. And that's what I was sharing with him. You go for a 2-day gamma knife course, and it used to be that you had to do 100 acoustics to get good at doing acoustics. And now you go for a 2-day course, and you can do an acoustic and press the button. The patient does great. But I want to open up for questions. Yeah.
Great talk. What are your approaches for small unruptured aneurysm? What are the factors you take in consideration in deciding whether to treat or not, and how to treat it?
That's a great question. I mean, that again speaks to the lack of knowledge we have about the natural history, right? Because we looked at our own ruptured aneurysms at UH Case Medical Center. 30% were less than 5 millimeters, and of those, 50% were ACOMs, right? And so we know, and neurosurgeons have known that for a long time, right? We selected those out in Ishua, and that's why they're not in the data. But so, I mean, high risk location is clearly something. Patient age, it's hard to recommend treatment for anything less than 3 millimeters. I don't use 7 millimeters as some kind of magical cutoff, though, at all. I think for patients that are, 65 or younger, we tend to be still fairly aggressive about recommending treatment for medium-sized aneurysms, 3 to 7 millimeters in size. But again, location is very important. Ophthalmic's a little different. We know those are lower risk for rupture. Probably don't treat those as often. But there are places that are pipelining every You talk about cavernous aneurysms that are, throwing up, stents in those. So, I don't know, what do you guys?
What are your, I use 7 millimeters.
Yeah.
I use 59 and 7. If you're over 59, I probably won't do any. But, part of the problem is that it's still an art. And that's the important thing with residents. If you're a 2-pack-a-day smoker and you're hypertensive, and you have a 5 millimeter, middle cerebral artery aneurysm, I would clip it. I just think, I clipped a 74-year-old with a 1 centimeter middle center dose, but her mother was like 90 years old and, alive. And I'm like, she says, all my parents are alive,
Right. Well, and it's physiologic age.
Exactly.
It's not absolute age. A wise man once said it's not the age, it's the mileage, right? So.
Dr. Keith Richards about that. Now he's got some mileage.
Right. So I think it is an art, but when we talk about it with the residents, I think we certainly go over the studies and the data. I don't think any of us as cerebrovascular neurosurgeons believes the 0.05% rupture risk applies across the board.
What number are you coding for unruptured?
Again, it's a little bit dependent on location, but I still talk to patients in terms of the 1% per year that we all kind of grew up on. If you look at the incidence of aneurysm rupture in the United States and the total population, that still is pretty much borne out from an epidemiologic standpoint. So, if you have somebody who's 70 and otherwise very good health and has a 6-7 millimeter aneurysm, Now, I do think age does matter for what type of treatment. The propensity analysis from issue 3, which they never published but presented, did show clearly that for patients who are older than age 65, endovascular treatment is probably preferred. For 50 to 65, there's equipoise, and for patients younger than 50, they tend to do better with surgical clipping. But we've all been in the older patient with tortuous anatomy, and it's a nightmare. And a 70-year-old splitting the fissure takes you, about 10 minutes, right? So, there is that to consider. That's why I think there's value to being able to offer both kinds of treatment, frankly.
Do you think we should offer treatment based on the payers, mainly if it's Medicare, Medicaid, the company should not get pipeline?
We do that for carotid stenting,
Right, that's
right? We do it for intracranial stenting.
They do it with the spine
Right.
surgery. You don't use the expandable cages for, those payers.
I have ethical problems with that.
But I think for the residents, it's important. Like you go to India, and the vast majority of patients cannot afford coil.
Right.
And you have to clip the aneurysm. Not only that, the family can only afford to pay for one clip. So you think about trying to lombardo your way through that. So you only use one clip, that's the one shot you have. And we're so spoiled, you want clip, another one here, add another one. We're like putting 3 or 4 clips in. So I think there's a luxury, and it's interesting, Pat Kelly, who was the NYU chairman, and he gave a legendary talk about Vietnam, how he was there at the height of the Tet Offensive. Well, he went back to Vietnam just to give back. He went and operated in Vietnam. And the thing that struck him the most, that these people had very little equipment, but they were meticulous technicians. There were no veiny clips. He said they opened the scalp and not a single RBC was leaking out. If I put it right there, the scalp looked healthy. So I think there's something to be said about becoming a better technician when you're resource depleted. It's simple. I always tell the residents, we discovered Janetta and there was no glue. You know what I mean? If your dura closure was not watertight, you went to the principal's office. If there was a leak, that was it. It had to be. And now we're like, just spray some glue. And I see this. We had a fellow, the guy opened the scalp and put flow seal everywhere. I'm like, that's $500. You can't do that.
Well, Dr. Ratchison used to make us do meningiomas without navigation for that very reason.
Really?
Yeah. Well, so think about the tools we have that we possibly overuse.
Costs should go down for flow diversion. The thing with flow diversion now is it's a monopoly.
What's that?
It's a monopoly right now.
It is. It is.
They're charging whatever they want.
Right.
Once we get the
a couple new ones, then we'll have
Yeah,
some
no, there is
competition.
clearly downward cost pressure on all the endovascular therapies, and I think that's going to continue.
It was very interesting to see that information. We did something similar, but just for ophthalmics, pipeline versus clipping, and is Remo here? I think it
You
ended up being
understand that,
ended up being the same thing.
We had, again, it was, we got our EPIC in 2011, and so the data was limited. Prior to 2011, we had been clipping, Dr. Andrew been clipping a lot more, but since then, the number of ophthalmic treatments was predominantly restricted to pipeline treatments. I think we had 5 clips during that time and about 15 pipeline treatments, for a total of about 20 ophthalmic aneurysms. And we found similar things to what you reported. Clips were staying in the hospital about 6 days, and then the pipeline patients were going home the next day.
Right.
There were no complications in either group, and the cost came out to be, there was no statistically different.
Yeah, and it was your length of stay that was driving
Yes,
that.
that's exactly.
But I bet if you looked at that last column that I showed, which was the ongoing cost, remember they need a couple angiograms a lot of time. The FAANS was one example. We've all had patients like that. That can add up pretty quickly, and especially when you're talking about folks that have to pay some out of pocket. You know, in Greece, we're all bankrupt anyway, so there's no, we
The
can't,
monks have
we
all the
can't,
money.
then we don't have, the
In
church
Greece,
has
all
all
the
the money,
monks
yeah.
have the money.
So we're selling islands of Turkey, I think, or something, so.
Piyush, any questions? He's done a lot of our research to the NIH database. He's put up some good papers on that. So. Any comments on Aruba? We can divert a little
Oh,
bit
my
on
goodness.
AVM,
Well-
sort of death knell papers on
Well, we
AVM.
talked about it a little bit in that we had a couple AVM cases. It hasn't really impacted my practice too much. I'm still seeing unruptured AVMs come through, and frankly, recommending or not recommending treatment the same way I always have, based on patient age and our 2 to 4% rupture risk. And surgery is the primary treatment of choice for grade 1s and 2s, and Gamma knife is a secondary option for older patients, and endovascular treatment is an adjunct, not a curative. All things that were completely ignored in Aruba, right? So, which is why you saw that complication rate. I haven't heard too much else. I don't think they got funded for extending the study, and folks in the CV section are continuing to talk about doing a study or doing a registry. I think things like participating in a quality registry like this will really help, because you're going to get adjudicated outcomes now, and you can use that to guide some of your treatment decisions too. The illusion that all of our grade 1 and 2 AVM surgeries have the same outcomes as Roberts in 1985, probably a little unfair, but we'll see, right? We'll see.
Well, we're getting the QOD. Dr. Bullen was doing that, so I think that should be good. Well, thank you again. Appreciate it.
Oh, geez, thanks. Terrific. Thanks,
Thank you.
Emil. Appreciate it.
Thank you so much.
Thanks.
Filotimo. You have
That's right.